Hello, good evening everyone. Today we are discussing a very important topic, type B aortic dissection. This topic is summarized from many books like Rutherford, Aortic Disease, Vascular Surgery, Principle and Practice, and Imaging was from presentation for Dr. Zakir Al-Khadiri. Now we are starting. Acute aortic syndrome consists of 5 diseases: aortic dissection, intramural hematoma, penetrating aortic ulcer, aneurysm, rapid expansion or symptomatic aneurysm, and trauma. This is a picture of an aortic dissection, picture of intramural hematoma, picture of a penetrating aortic ulcer. So the acute aortic syndrome consisted of 5 diseases: aortic dissection, intramural hematoma, penetrating ulcer, rapid expanding aneurysm or symptomatic aneurysm, and trauma. Anatomical classification of the aortic dissection, the Becky classification, which depend on the origin of entry tier. Type 1 originating at the ascending and aortic arch and descending aorta. Type 2 it originating at the ascending aorta. Type 3 it originating at the descending aorta. Stanford classification depend on if the ascending aorta is involved or not. Type A dissection is involving the ascending aorta. Type B all dissection that don't affect the ascending aorta. So the anatomical classification, we have the Becky classification, the entry tier or the section tier originating from which point? The wall aorta type 1, ascending aorta type 2, descending aorta type 3. Stanford classification, do the ascending aorta involved in the dissection is type A or not involved in the dissection, it is type B. This is the picture of the Becky type 1 originating at the ascending arch descending, type 2 ascending, type 3 descending, and this is Stanford classification type A involving of the ascending aorta, type B doesn't involve the ascending aorta. The clinical classification for the type B aortic dissection: acute aortic dissection, non-complicated or complicated, indicated for treatment. Malperfusion lower limb like acute ischemia, visceral mesenteric ischemia, rupture of the false lumen, presence of the rapid expansion, refractory hypertension, pain during the acute phase. All are complications which is indicated for treatment. Subacute state or chronic phase, the main indication for treatment if it's complicating, and the complication in the chronic phase in the form of ongoing expansion of the false lumen and extension of the dissection. So the first classification was anatomical classification, Stanford and Becky. Another classification is clinical classification. Acute aortic dissection, acute means within first 2 weeks. Either it is non-complicated for best medical therapy or complicated for intervention. Malperfusion of lower limb cause acute ischemia, visceral cause mesenteric ischemia, rupture of the false lumen, presence of the rapid expansion, refractory hypertension, and pain during the acute phase, while subacute from 2 weeks up to 6 weeks or 12 weeks, and chronic phase more than 6 weeks or 12 weeks. The main indication for treatment is the complication, ongoing expansion of the false lumen, and extension of the dissection. So, what is the differential diagnosis for the acute aortic dissection? Patient presented with acute chest pain. It may be acute type B aortic dissection or type A aortic dissection. Either also, it may be MI, pulmonary embolism, spontaneous pneumothorax. Patient presented with acute abdominal or back pain. It may be acute aortic dissection. It may be also ureteric colic, perforated viscous, mesenteric ischemia. Patient presented with pulse deficit. It may be acute aortic dissection or non-dissection related embolic disease. Patient presented with focal neurological deficit. It may be aortic dissection. It may be stroke, quadra equina syndrome. Management of the aortic dissection rely on mnemonic D6. D for duration, acute mean the first 2 weeks of presentation, subacute between 2 weeks up to 6 weeks, and in other literature to 12 weeks. Chronic that mean more than 6 weeks or 12 weeks. Size of aorta and false lumen, site, type AB for Stanford, type 1 to 3 for DBK. Segmental extension, extended to the viscera, extended to the which renal, extended to which iliac. Clinical complication like rapid expansion, severe pain, rupture, limb ischemia, mesenteric ischemia, uncontrolled hypertension, thrombus within the aortic false lumen. So the management of the aortic dissection rely on mnemonics dissection. D for duration, acute, subacute, and chronic. Size of the aorta and false lumen. Cite the anatomical classification of the dissection type A, B for Stanford, 1 to 3 for DeBakey. Segmental extension, clinical complication, and C for thrombus within the acute aortic false lumen. International Registry of the Acute Aortic Dissection reported acute type B dissection that mean within 2 weeks, those managed conservatively, has 30% in hospital mortality, and most of these patients died within 1 week. Subacute phase that mean between 2 weeks up to 12 weeks after presentation. This may be the optimum time to undertake the intervention treatment for uncomplicated lesion. Undertake intervention treatment here mean TEVAR. So it's preferable to undertake the interventional treatment in subacute more than in acute type B dissection. Maybe has less complication. Instance of acute aortic dissection. The annual incidence of the acute aortic dissection is 3 per 100,000. Circadian and seasonal variation more in the morning and winter months. Increase the aortic diameter size, that means aneurysm. More than 6 cm, it has a risk of aneurysm rupture or dissection formation. And when the aortic diameter more than 7 cm, the incidence will be increased to be communicated with aneurysm rupture or aortic dissection. So, what are the risk factors for acute aortic dissections? Number 1, hypertension. Systemic hypertension is an important risk factor in pathogenesis of aortic dissection. Higher systolic blood pressure will increase the velocity of the ejection fraction from the left ventricle and increase the shear stress experienced by the outer curvature of the aortic arch. Number 2, race and gender. Study of the international aortic dissection registry revealed that 68% of the all patients were male and 79% were white. Black patients are common young in age, hypertensive group with left ventricular hypertrophy. Number 3, connective tissue disease. Connective tissue disease lead to weakening of the aortic wall, increasing the risk of dissection, like in Marfan, Ehlers-Danlos type 4, and disorder associated with cystic medial necrosis. Congenital cardiovascular abnormality. Bicuspid aortic valve is related to type A aortic dissection. Coexistence of coarctation of the aorta, and group of familial aneurysm syndrome, like congenital contractural arachnoidectomy, familial thoracic aortic aneurysm, Erdheim cystic medial necrosis, familial aortic dissection, familial ectopia lentis, Marfan-like habitus, and so on. So, connective tissue disease and congenital cardiovascular anomaly are risk factors for acute dissection. Aortic vasculitis disease like Takayasu, giant cell arteritis, Behçet'in aortitis, and syphilis. Cocaine use, pregnancy in the third trimester especially, and the iatrogenic cardiac intervention and the trauma. What is the clinical picture? Clinical picture for the acute aortic dissection is pain, abrupt onset of sharp tearing pain or stabbing pain at the chest radiating to the back or to the shoulder. The pain is absent in 10% in the diabetic patient. Number 2, acute rupture or malperfusion may lead to rapid collapse and death. Neurological deficit, it may be stroke, it may be paraparesis, paraplegia, and so on. Symptomatic limb ischemia with 6 beason or visceral ischemia. Hypotension in patients with type A dissection and hypertension in patients with type B dissection. Chronic dissection is often asymptomatic, but it can be associated with ongoing back pain or compressive symptoms related to the aneurysm. So the clinical pictures for the acute aortic dissection is acute sharp tearing chest pain radiating to back or shoulder and may be absent in diabetic patient, acute rupture and collapse and death, neurological manifestation, symptomatic limb ischemia manifestation, visceral limb ischemia manifestation, and hypotension in type A, hypertension in type B, and also complication related to rising kidney function if it's involving the both renal artery and causing pre-renal failure. Chronic dissection is often asymptomatic but may be associated with ongoing back pain or when it's complicating with extension of the dissection, it may be has a compressive related symptoms. So what are the theory for etiology of the aortic dissection? Number 1, degeneration plus mechanical force. We have genetic predisposition, we have medial degeneration, which stimulate inflammation and injury to the medium, loss of the smooth muscle, and damage by cytokines. Aneurysmal formation, dilatation cause mechanical stress on the wall, hypertension episode, end by aortic dissection. Other theory is pooling of the glycose cause aminoglycan and proteoglycan in the media cause delamination within the media, initial degeneration process within the media, and later on also hypertension episode aortic dissection. So classical aortic dissection is a longitudinal split or a partition in the media of the aorta. Smaller true lumen is lined by the intima and false lumen is lined by the median. Here is the entry theorem inside the intima and separating between the intima and median. Smaller true lumen is lined by the intima, false lumen is lined by the median. Typically, flow in the false lumen is slower than the true lumen. The false lumen often become aneurysmal when subjected to systemic pressure. History and examination. The history should include specific questions about the genetics, connective tissue disease, and familial condition. History of recent aortic procedure for atherogenic, chest pain, abdominal pain, and limb peripheral pain. Examination for pulse deficit, unequal blood pressure in case of left subclavian involvement artery, malperfusion for the lower limb ischemia, mesenteric, and neurological examination. Investigation ECG is often by about 70% abnormal, but we don't have specific signs present in ECG is related to acute aortic dissection. D-dimer is elevated more than 500 nanogram per milliliter within 24 hours of acute chest pain, and it may have a role to rule out acute aortic dissection if it is all negative. Chest X-ray is abnormal finding. We have common abnormal finding, but all of them are non-specific. This is a finding for chest X-ray in acute aortic dissection. We have here a mediastinal widening, which is the most common plain radiographic finding in the aortic dissection, and it is noted in 80% of the patients. We also may have also irregular aortic contour and double density knob sign. Echo, we have two types of echo, transthoracic, which has less specific and sensitive to type B aortic dissection is about only 40%, and we have more specified for and more sensitive for type B aortic dissection transesophageal echo. More accurately visualize the entire thoracic aorta. It can be performed at the bedside and it can be adjuvant to endovascular repair due to ability to see devices within the aortic lumen. So here is a transesophageal echo and give impression for the true lumen and for the false lumen It gives a better impression for the ascending aorta and also can be useful to diagnose some congenital cardiac disease like congenital bicuspid aortic valve and other conditions. MRA advantages of MRA. High sensitive and specific when used to diagnose the aortic dissection. Gadolinium contrast agents used are less nephrotoxic than iodinated. There is no associated ionizing radiation. It can be used in dose with the nitinol aortic stent graft. For this CNE-MRI technique may offer the potential for dynamic assessment of the aortic dissection to determine the nature of the blood flow within the true and false lumen. These advantages are used in patients with claustrophobia or metal devices, long acquisition time, and limited availability. That means it is not suitable for the emergency condition. This is the picture of type B acute aortic dissection in MRI, and this is a picture of MR4D, which can give some dynamic of flow through the true and false lumen by this way. CD angiography. Advantages of the CD angiography. Multi-detector CCA is the preferred investigation for acute aortic dissection. CCA has a sensitivity of 95% and specificity of 98%. It has short time processing, rapid and immediate visual assessment of the aortic morphology. 3D multiplanar reconstruction is available. It assesses communications such as contained rupture or malperfusion. Disadvantage: the need to use potentially nephrotoxic contrast media, exposure to ionizing radiation, inability to assess functional aortic insufficiency. Contrast enhances CC like this condition we have here type B aortic dissection. Most commonly used sensitivity, as we have said, 95% and specificity 98%, as you can do ECG gating. Intravenous contrast is necessary to visualize the true and false channel, visualizing the communication like hemopericardium, aortic rupture, branch, and vessel involvement. How we can differentiate between the true lumen and false lumen in CC angiography? True lumen is surrounded by calcification in presence, smaller than false lumen, usually the origin of the celiac trunk, superior mesenteric artery, and right renal artery, while in false lumen, flow or occluded by thrombus, delayed enhancement, wedge around the true lumen, peak sign, collagenous or soft tissue material or remnant, cobweb sign, larger in size than true lumen, outer curve of the arch, usually origin of the left renal artery, and surround the true lumen in the type A dissection. So those are differentiation between the true lumen and the false lumen. True lumen surrounded by calcification, smaller in size, usually origin for the celiac trunk, superior mesenteric and right renal artery. The false lumen is the flow is occluded by thrombus, delayed enhancement. We have two signs, peak sign, wedge around the true lumen, and collagenous medial remnant, cobweb sign, larger than the true lumen, outer curvature of the arch, usually origin of the left renal artery, and surround the true lumen in the type A dissection. This is true lumen, rounded or oval in shape. Strong systolic Doppler velocity can be detected. Thrombus is rare. This is the false lumen. We have a crescent in shape. We have a sluggish flow or no flow by Doppler velocity. We have thrombus is common. We have soft tissue shadow organ that's called cobweb shadow. And we have also what's called wedge around the true lumen. This wedge around the true lumen called peak sign. Okay, this stands for type A typical aortic dissection. Sequential contrast enhancing CD show a peak sign. This is a peak sign. That means this is the false lumen and this is the true lumen. So we have peak sign here, crescent shape, and here is the true lumen, which is surrounded by calcification. Contrast enhancing CC scan of the Stanford type A aortic dissection. So atherosclerotic calcification in the aortic wall, aortic lumen, indicating this is the true lumen. We have here calcification, which is present in the intima, which is lining for the true lumen. So this is the true lumen, and this is the false lumen. The same condition here. This is the true lumen, and here we have the false lumen. Classical aortic dissection cobweb sign. This is the shadow present in the false lumen is called cobweb sign. Linear trace of the low attenuation in the false lumen. And this is the true lumen. We have here also cobweb sign for the false lumen. We have here also what's the called the peak sign. This one. This is the crescent present around the true lumen, which is called the peak sign. So this is the false lumen, this is the peak sign, this is the true lumen. This is the false lumen, this is the cobweb sign, this is the true lumen. We have here also for the white arrow attenuation of the thrombus. This is thrombus presenting in the false lumen, and this is the true lumen. And inside the false lumen we have a soft tissue shadow is cobweb sign. This is the calcification, that means this is the true lumen. This is the thrombus, that means we have a false lumen. False lumen being we have thrombus here, true lumen being we have calcification, and this is the dissection flap toward the innominate dissection at aortic arch, and the false lumen surrounding the true lumen and the bilateral pleural effusion. So, what is the morphological change of type B aortic dissection over the time? By the time day 0, 14, after 6 weeks, 6 months, after 1 year, after 4 years. By the time we have increased aortic diameter, we have increased intimal thickening, we have increased false lumen thrombosis. By the time we have decreased flap motion over the time, and we have decreased the curvature, like this. This is the high curvature, more straight curvature by the time, become more straight. So the aortic diameter should be increased or suggested to be increased by the time. Intimal thickening suggested to be increased, and false lumen thrombosis will be increased. By the time flap motion over the time will be decreased, and the curvature of the flap will be decreased. Acute complicated type B aortic dissection. We have open surgery was mainstay treatment in the past with 30% of mortality and high morbidity. It includes risk of post-lateral thoracotomy, single lung ventilation, cross-clamp of the aorta, cardiopulmonary bypass, hypothermia, and CSF drainage. Endovascular treatment for acute complicated type B, self-expandable endograft. The aim is to cover entry tier, promote expansion of the true lumen, and decompression of the false lumen. Second intervention may be required for iliac artery, visceral aortic branch revascularizations. It is the current first-line treatment for acute complicated type B aortic dissection. Meta-analysis for 942 patients received endovascular treatment in TEVAR show mortality 9%, morbidity 8%, re-intervention 10%, and the risk of fracture is only 1%. Virtual registry reported less serious complication when the endovascular intervention TEVAR applied for subacute aortic dissection more than acute aortic dissection. We have a better aortic remodeling, compression of the false lumen, and expansion of the true lumen. Are seen open endovascular treatment in acute subacute state more than in chronic state, being we have a rigid flap. So in this slide, we are comparing between the open surgery and intervention for the acute complicated type B aortic dissection and endovascular treatment. The open surgery has a high risk of morbidity and mortality, and complication of posterolateral thoracotomy, single lung ventilation, cross clamp of the aorta, cardiopulmonary bypass, hypothermia, CSF drainage. And here in endovascular treatment, we have less morbidity and mortality. We have 9% mortality, 8% morbidity, reintervention 10%, 1% for rupture, So the aim is to cover entry tear, promote expansion for the true lumen and decompression of the false lumen. Better result when it is conducted during subacute aortic dissection more than acute aortic dissection, and better aortic remolding in the form of compression of the false lumen and expansion of the true lumen if the treatment is conducted in acute subacute state more than the rigid flap of chronic state. TEVAR treatment modality of the choice in complicated acute type B. Focus is occlusion of the primary entry tear. The size of the stent graft should be based on diameter of aorta proximal to the dissection segment, applying almost no oversizing. Sufficient length 1.5 to 2 cm of the proximal landing zone is important and mandatory. Ballooning is not recommended even if stent graft is not fully expanded. Retrograde expansion is a risk, and rupture of the dissection membrane is also a grave risk. So this is the instructions or some point of view for the TEVAR. TEVAR is the modality nowadays in the treatment of complicated type B aortic dissection. The aim is to occlude the primary entry tear. The size should be based on the diameter of the aorta proximal to the dissection segment. We have sufficient proximal landing zone 2 cm almost. Ballooning is not recommended, even is not fully expanded for the risk of retrograde type A aortic dissection and risk of rupture of the dissecting membrane. And we have also the size. Avoid oversizing in case of type B dissection. Okay. We have here sagittal contrast enhances CC aortic dissection type B. The entry tear dashed arrow is immediately distal to the left subclavian artery. And here we have eye vessel catheter inside the true lumen, and this is the false lumen. And here we have graded pigtail present in the true lumen. And in the pictures we have insertion of and deployment of endograft, and the end one is coverage of left subclavian artery. Endovascular stent graft in type B dissection, we have here an entry tear, and the main rule of the TEVAR is to cover the entry tear. Okay. Treatment of the acute non-complicated aortic dissection. So we have discussed what is the treatment of acute complicated aortic dissection type B, and we have two options of treatment. TEVAR is the best choice nowadays, and in the past was open. But what if we have acute non-complicated type B aortic dissection? What is the mean of the complication? Complication mean rapid expansion, rupture, and collapse. That means severe persistent pain, uncontrolled hypertension, limb ischemia, mesenteric ischemia, neurological manifestation. Study classify patients with acute non-complicated aortic dissection into three groups with follow-up. Who need for early intervention or late intervention 5 years? Who has the complication? The first group complete thrombosed false lumen. So it not require early intervention, and only 20% of the patients require for late intervention after 4 weeks. But the second group, we have partially thrombosed false lumen. 16% require early intervention, being is complicated, and 20% of the patients require late intervention. In the third group, patent non-thrombosed false lumen with a higher percentage of early and late intervention. What does it mean? It means that when we have false lumen and it is beta non-thrombosed, it has a higher risk for early intervention and late intervention after 4 years, being is complicated. While if we have complete thrombosed false lumen, we have the lowest risk for early intervention and late intervention. The main line of the treatment of the acute non-complicated aortic dissection is best medical treatment. Best medical treatment consists of management of the pain, reduction of the blood pressure to an acceptable level, and close observation should occur in ICU. Timing for treatment of the acute type B aortic dissection. Outcome of the immediate endovascular treatment for acute non-complicated type B aortic dissection is worse than subacute states. In selected cases with low blood pressure, resistant pain, large stable false lumen, they would have more benefit with intensive observation and medical treatment until it becomes subacute states. Medical treatment should be continued once intervention has selected to do being is an ongoing pathology. So in that point, we are doing best medical treatment in TEVAR. Okay, so the timing of the acute type B aortic dissection. If it's not complicating, best medical treatment and close monitor until the patient changed from the acute within 2 weeks to subacute between 2 weeks and 6 weeks or 2 weeks up to 12 weeks. At this point, we can do intervention in the form of TEVAR. TEVAR and best medical treatment should be conducted and best medical treatment should be continued, being an ongoing pathology. Here we have a very famous two trial, N-state XL trial, endovascular repair of type B aortic dissection, long-term result of randomized investigation of stent graft in aortic dissection trial. In this trial, 140 patients with stable, uncomplicated type B dissection between 2 to 52 weeks. We randomly assigned to best medical therapy alone or best medical therapy plus endovascular. The primary endpoint is all-cause mortality at 2 years and 5 years. The secondary endpoint is aortic-related death and aortic remodeling. The result of N-state XL trial. Mid-term all-cause mortality was similar in both groups, the medical and intervention. Aortic-specific mortality, later disease progression are lower in TEVAR group. Aortic remodeling complete false lumen thrombosis is achieved in the TEVAR group by 91% and only almost 20% in best medical treatment. 40 cases over time were converted from best medical treatment group to TEVAR group, being they developed complication. So in Steden XL trial, this trial conducted over 140 patients with stable, uncomplicated type B dissection between 2 weeks to 52 weeks, randomized between we have best medical therapy group and the TEVAR group plus best medical therapy. And the primary endpoint all-cause mortality, the secondary endpoint aortic-related death and aortic remodeling, and the follow-up at 2 and 5 years. Result, we have almost equal all-cause mortality in both groups, but the secondary endpoint is different. Aortic-related mortality is lower in TEVAR group. Aortic remodeling is better and achieved in TEVAR group. Absorb trial, endovascular repair of acute uncomplicated aortic type B dissection, promote aortic remodeling 1 year result of an absorb trial. It classifies non-complicated type B aortic dissection into TEVAR plus best medical treatment group and best medical treatment only group. The primary endpoint is aortic remodeling at 1 year. The result is better aortic remodeling thrombosed false lumen at TEVAR group, and we have a non-significant survival benefit for TEVAR group. So absorb trial differentiating the cases of non-complicated type B aortic dissection as regard aortic remodeling, who can achieve the aortic remodeling. Aortic remodeling mean thrombosed false lumen and widening of the true lumen at 1 year, and the resultant is better achievement for the aortic remodeling for the TEVAR group. The conclusion of those trial data: if we have an acute type B complicated, we are going to do intervention, either it is endovascular TEVAR or open. The two trials, absorb and state trial, differentiate between if we have a non-complicated aortic acute type B dissection, we have almost equal as regard all-cause mortality, but we have a better aortic remodeling and less aortic-related death in case of the TEVAR. And the conclusion also of our talk is that if we have acute type B dissection and we can manage it on the best medical treatment is better, being when we wait until it become subacute and we started in the second week, we have a better result if you have conduct intervention at subacute state more than acute state. Finally, at this point, what is the fate of the false lumen after TBAR? Decreased false lumen and increased true lumen is called aortic remodeling. Total thrombosis at level of stent resertion by 80 to 90% within 1 year. Lower incidence of thrombosis at below diaphragm level. Progressive expansion of the true lumen with shrinking of the false lumen. Lower incidence of endoleak, better distal perfusion. What are the factors that give poor outcome of uncomplicated aortic dissection? When you have partial thrombosis or no thrombosis of the false lumen. And we have discussed them before in a study. When we have complete thrombosed false lumen, it has less instance of early intervention and late intervention after 4 weeks, being it is less complicating. But if we have partial thrombosis or no thrombosis, it has more instance of early and late intervention, being it's complicating. When we have a sacral false lumen or elliptical false lumen, it carry poor outcome. When you have aortic diameter more than 4 cm or false lumen diameter more than 2.7 cm, it has poor outcome. When you have a large proximal entry tear or multiple tears, it carry poor outcome. And finally, connective tissue disease. Chronic aortic dissection. Chronic aortic dissection managed merely conservative, 50% complicated by aneurysm. Conventional open surgery has an appreciable death rate and possesses considerable physiological challenges, so it is very risky. Endovascular approach is associated with less morbidity and mortality, with higher incidence of reintervention. Role of TEVAR in chronic type B aortic dissection. TEVAR is indicated in case of complicating chronic type B dissection, like in case of rapid aneurysm growth or rupture. It has less morbidity and mortality in comparison to open surgery, with higher risk of reintervention. We have also limited role in aortic remodeling and false lumen obliteration due to more rigid and stiff intima. We are discussing about new techniques in the type B thoracic aortic dissection. Bitico technique, provisional extension to induce complete attachment technique. Deployment of the beer stent distal to cover stent in the thoraco-abdominal aorta in order to increase the true lumen size, treating dynamic malperfusion and stabilize the intimal lamella. It offers good short-term and mid-term results. However, some degree of perfusion of the false lumen is still maintained, and aorta still has tendency to grow distally to stent graft. This trial is a stable trial. Bitico technique. Entry point is sealed with endograft. This is endograft or cover graft, and remaining thoracic and potentially abdominal aorta stent with opened bare metal stent, and decrease the chance of the true lumen collapse, enhance the aortic remodeling, and promote the false lumen thrombosis. The second technique is stabilizer technique, stent associated balloon induced internal disruption and relamination in the aortic dissection repair technique. Technique of the ballooning true lumen inside the stent graft plus distally deployment of bare metal stent to rupture the lamella, and it allows full expansion of the stent in a single channeled aorta. It has a good result regard rate of intervention and relief of malperfusion with the risk of rupturing the aorta during ballooning. It needs suitable only patients with acute and subacute type B aortic dissection with proximal suitable non-dissecting proximal landing zone and aortic arch or descending thoracic aorta. The total abdominal aortic diameter true human and false human must not exceed 42 mm. Proximal covered stent graft cover the proximal dissection entry tier with maximum oversizing 10%. Second, cover stent graft if needed. Intestinal thoracic aorta deployment need a generous overlapping with the previous one at least 5 cm with 10% oversizing. Distal land zone should be the diameter less than 42 mm and at a distance of 50 to 100 mm from the celiac trunk. Distally, to cover the stent, deploy the perimeter stent equal to the total aortic diameter through lumen and false lumen. 46 mm compliant balloon inflation inside the cover stent. Need to make obliteration of false lumen and rupture of intimal lamella and obtain relamination. Non-compliant or semi-compliant balloon dilatation inside the perimeter stent not exceeding the total aortic diameter at this level to rupture the intimal lamella and obtain relamination. Cannulation of the branches arises from the false lumen and followed by cover stent deployment. Additional obey or cover stent may be needed or used in common iliac artery to obliterate the tear distally. IVAS can be used during the procedure to better determine the true and false lumen, and transverse echo can be also performed and can assess and visualize our catheter and wires. Conclusion: stabilized technique is safe and reproducible technique for treatment of persistent false lumen patency distal to stent graft in complicated acute and or subacute dissection. So the petticoat technique in this picture we have here type B aortic dissection. Petticoat mean after we have deployment of the covered endograft stent to cover the entry tier of the aorta type B dissection. We can continue the remaining thoracic or aortic aorta using perimeter stent. In case of stabilized technique, we are doing ballooning. Here is compliant semi or non-compliant balloons for the endograft and perimeter stent to make rupture for the lamella. Follow-up serial imaging of the entire aorta should be performed, including a discharge 1 month, 3, 6 months, and 12 months after discharge. Long-term annual imaging should be considered based on the patient's stability and the clinical context. Lastly, we have guidelines from European Society of Vascular Surgery for type B aortic dissection. Medical therapy should always be a part of treatment of patients with acute type B aortic dissection. In patients with acute type B aortic dissection, beta blocker should be considered as the first line of medical therapy. In patients with acute type B aortic dissection who don't respond or are intolerable for beta blocker, we can consider calcium channel blocker or renin angiotensin inhibitors. In patients with complicated acute type B aortic dissection, endovascular repair with thoracic endograft should be the first line of intervention. In complicated type B aortic dissection, endovascular infiltration should be considered to treat the malperfusion. To prevent aortic complication in uncomplicated type B aortic dissection, early thoracic endograft may be considered selectively. In acute complicated type B aortic dissection, open repair should be considered as an alternative to endovascular therapy following failure of endovascular management or where endovascular intervention are contraindicated. Recommendations for and guidelines for chronic type B dissection. In patients with chronic aortic dissection, effective hypertensive therapy should be considered and given to reduce the risk of the aortic-related death. In patients with chronic dissection, measures to reduce cardiovascular risk such as treatment of the hyperlipidemia, antiplatelet therapy, management of the hypertension, smoking cessation should be implemented to reduce incidence of the late cardiovascular death. Long-term medical treatment with beta blocker should be given to patients with chronic uncomplicated aortic dissection as they reduce the progression of the aortic dilatation and the incidence of the subsequent hospital admission and need for late dissection related aortic procedures. In patients with chronic aortic dissection and acute aortic symptoms, emergency repair should be considered if malperfusion, rupture, or progression of dissection is confirmed on imaging. In patients with chronic aortic dissection, the descending thoracic aorta diameter between 56 to 59 mm may be considered as indication for treatment in patients at residual surgical risk. In patients with chronic aortic dissection, descending thoracic aorta diameter greater than 60 mm should be considered as indication for treatment in patients at residual surgical risk. In patients with chronic aortic dissection and thoracoabdomen extension, an aortic diameter greater than 60 mm should be considered as indication for treatment in patients with at residual surgical risk. Open repair of the aneurysmal or symptomatic chronic type B aortic dissection in patients with low surgical risk should be considered in dedicated centers with low complication rate. In patients with chronic type B dissection undergoing operative repair, intra-procedural CSF, left heart bypass, moderate hypothermia should be considered to reduce the procedural mortality and spinal cord injury. So he considering CSF drainage, left heart bypass, and hypothermia to reduce the spinal cord injury. In patients with moderate to high surgical risk with or contraindication to open repair, endovascular repair of complicated chronic type B aortic dissection should be considered in dedicated centers. In patients at risk of the further aortic complication with suitable anatomy for endografting endovascular repair of uncomplicated chronic type B aortic dissection should be considered in the subacute phase in dedicated centers. Thank you very much for your attendance.